everyone. Hopefully everyone can see and hear me. I'm just going to get things started now. So thank you everyone for joining and for signing up today. Just to introduce myself, my name is Hannah Candy. I manage the Domestic Homicide Review Team at Standing Together Against Domestic Abuse. I'm just going to go over a bit about housekeeping and some introductional type bits, and then I'll hand it over for the session today. So just so that everyone is aware, you might have seen it pop up, this session is being recorded and it will be available. We'll post it on our website, so anyone that can't make it today, or if you wanted to rewatch certain bits at a later date, it will be available online, as will be the PowerPoint if you want to use that at a later date. Just to note, this is our fourth session, I believe, and all of our previous sessions are also available online. We've had loads of great speakers and great presentations on a range of topics, including fatal adult-child parent abuse, intersectionality, and DHRs, as well as the DHR process itself, both international perspectives as well as how locally they're actually implemented. So if you are interested in any of those other areas, please do check that out on our website. You'll see we have a chat function, so feel free to introduce yourself or type any comments in that chat. If you do want to just make sure it's clicked down to being towards a panelist and attendees, just so that that way everyone can see it. Or if you just wanted to type something to the panelists, that's fine as well, but just be aware that the rest of the group won't be able to see that. We also have there at the bottom a Q&A function, so you can put any questions in that and also upvote any questions that you want to make sure get answered. We will have time at the end to do Q&A. We can't promise that we'll be able to get to all of them, but if you do have any questions that aren't answered or that you think of later, our details are on the screen here. You can see our email, as well as it should have been in your Zoom invite, et cetera, et cetera. And our last bit of kind of housekeeping side is, if you are on Twitter and you're going to be tweeting from today, we have the hashtag that we've been doing for the series. If you could either hashtag that or tag either Standing Together or Dr. Calcia, either one of us, just so that we can make sure that we're seeing that and kind of not upvoting them, what is it called? Retweeting as appropriate, and we'll also be tweeting throughout that event as well. So in case any of you are new and haven't been to any of our other sessions, just to introduce Standing Together, we are a national charity whose aim is to end domestic abuse by trying to change the way that local areas respond to it through an approach that we pioneered in the UK called the Coordinated Community Response, or CCR, sometimes it's referred to as. We believe that this coordinated community response is absolutely vital to ensure local systems truly keep survivors and any dependents safe, hold abusers to account, and ultimately to prevent domestic abuse. We work with a range of professionals, and we have loads of different trainings that are all available on our website. So if you do want to check that out and look at any further trainings or webinars, we also have a few jobs going at the moment. So if you're interested in working with us, please do check that out. Also, if you just have any other questions that maybe aren't answered, please feel free to contact us on the emails provided. So obviously today the speaker for this session is Dr. Marilia Calcia. Dr. Calcia is a consultant psychiatrist at King's College Hospital and South London and Maudsley NHS Foundation Trust. She is also a doctoral researcher at the section of Women's Mental Health at King's College London, and her current research focuses on the response of healthcare services to perpetrators of domestic violence and abuse. This webinar is going to be talking about the themes surrounding the mental health of both victims and perpetrators of domestic homicides, based on the qualitative analysis that she did on 10 DHR overview reports for the Standing Together report, which was launched towards the end of last year and is available online to read from our website as well if you're interested. But without further ado, I'm going to be quiet and hand over the reins to Marilia. There you go.
Hi, thank you so much, Hannah, for the introduction and all the housekeeping. So I'm just going to start sharing my slides now. 1 second. Okay. So can everyone see my slides? Tell me.
Perfect.
If not, yeah. Okay. So thanks for joining today. It's great to see so many people, including some familiar names in the participant list. So today we've got about an hour and a half. So my actual presentation, I'll try to keep it under 1 hour, and then we have some time for questions. So I'm going to talk to you about mental health and domestic homicides. And although my research for my doctorate is to do with domestic homicides and mental health as well, this particular data, the data I'm going to present to you today is part of the London Standing Together report that was published last year, commissioned by the Mayor of London. And it was written by Bear Monteith, who was the interim CEO at Standing Together at the time. So I contributed to the mental health chapter, which is what I'm going to present today. So just a summary of what I'm going to talk about. So I'll just give you a brief introduction about domestic abuse and mental health. I'm going to talk to you about the report and the mental health chapter. I'm going to go through some detail in the cases that I analyzed, because it's just 10 cases. So I think we are able to go through some detail there. And the take-home messages for people who are practitioners in the area, both in the health sector and the DVA sector as well. And then we can talk a bit more about how healthcare services can respond to DVA safely, and open to questions and discussions, because I'm sure we've got a lot to learn from you who are in the audience as well. So starting with just setting the scene in terms of what we know from research about domestic abuse and mental health. We know a fair bit about domestic abuse and people who are domestic abuse survivors and their mental health. And what we do know is that people with mental disorders are more likely to experience domestic abuse. And when they do, this tends to be more severe and tends to have more severe consequences for their health than when it happens to people who do not have mental health problems. So people with mental disorders are more vulnerable in that sense. But on the other hand, people who have experienced domestic abuse are more likely to develop mental disorders in the future because of all the effects and the trauma associated with DVA. For example, we have this survey who was conducted in London between 2011 and 2013 in 2 mental health trusts. So this survey was really interesting because it showed that of the women who assessed mental health services in those trusts, 27% had experienced DVA within the past year. This is 3 times higher than the figures in women in the general population. So for any mental health practitioner or health practitioners who is seeing someone who is known to have a mental disorder, just be aware that the chances of that person, if they're a woman, experiencing DVA in the year before is more than 1 in 4. In men, the figures are also higher. So 13% of men had experienced DVA within the past year, which was twice higher than in the men in the general population. In terms of lifetime risk, if people had experienced DVA at any point in their lives, this was extremely high. So women who use mental health services had, almost 70% of them had experienced DVA within their lifetime. And with men, it was almost 50%. So these 2 figures, they were 4 times higher than the figures in the general population. So knowing this, when we work in health services, we really need to think about domestic abuse as a precipitator of mental health problems, as something that predisposed to mental health problems, and also something that will perpetuate mental health problems. Not to mention that even if the person we are seeing hasn't experienced abuse yet, they are more likely to experience it in the future. And and I know that for those of you who work in the DVA sector, this is very basic, but just to be clear that when I'm talking about DVA here, I'm using definition that we use in the UK that includes intimate partner violence and adult family violence. This is particularly important because, as we will see later, in mental health services in particular, there is a tendency of services to think about DVA as just intimate partner and not seeing family violence as the same thing. So you see here that I will reference a lot this resource called LARA VP. LARA stands for Linking Advocacy and Recovery. And VP stands for Victims and Perpetrators. And this is part of the project. LARA was a project that was done with King's College London that linked domestic violence advocates with health services to support survivors of abuse. And out of that project, they created this resource, which is really, really brilliant. You can find it very easily by just Googling LARA-VP PDF or resource, and it will take you to the King's College London page where you just put a few details and then you access the PDF. It's a brilliant resource to help health services, mental health in particular, to identify and respond to DVA. So I really encourage people to look into that. Now, when we talk about DVA perpetration in mental health, the data we have is a little bit more scarce, unfortunately. So we do know that men and women with a mental disorder, any kind of mental disorder, are at a higher risk of experiencing and perpetrating domestic abuse comparing to the general population. And if we think of the more severe end of the spectrum in domestic abuse, if we think of domestic homicides, which is our topic today, we will see, for example, that in England and Wales, out of the perpetrators of intimate partner homicides, in this sample covering over 10 years, 1997 to 2008, 20% of people convicted of intimate partner homicide had symptoms of mental illness at the time of the offense. This is not to say that necessarily there will be a causal relationship, that they would have killed because of those symptoms, right? But it's very, very significant to know that they were symptomatic. And when we talk about adult family homicide, this was even more. It was a third, 34% of the perpetrators had symptoms of mental illness at the time of the offense. And then the Home Office did an analysis of domestic homicides in 2016, and they found that in the sample they analyzed, 74% of the intimate partner homicides, mental disorder was a factor. When they say it was a factor, again, it doesn't mean that the person killed because of the mental disorder. It doesn't mean that the person got, the sentence was manslaughter rather than murder. It just means that they had known mental health problems. And with the family homicides, which is a smaller sample of 7, in all of them, mental disorder was a factor. So we start seeing here a trend for the domestic homicides that are adult family homicide being even more linked to mental health. Now, when we talk about drugs and alcohol, psychoactive substances, we do know that people who use drugs and alcohol, in particular alcohol, they are more, there is an association between that and the perpetrator of intimate partner violence. How and why, we don't know. So at this time, we can't say for sure that, most of these incidents are because the perpetrator is intoxicated or because they are in withdrawal, or for other reasons. It could be, for example, common mechanisms. So people who drink excessively or use drugs, they are more likely to have mental disorders, or they are more likely to have problems with employment and housing, or in unstable relationships. So at the moment, it's difficult to be clear on why, but we know that there is an association. And I'm mentioning this, but just to say, when we see in the media about mental health, sometimes substance use is included, but when you are a mental health clinician or researcher, we normally separate mental health problems from problems that come solely to do with substance use. So we'll see more specifically that in the themes. Now, talking more detail about the specific mental disorders and how they will affect the risk of domestic abuse perpetration. So normally talking about mental health and violence, the conversation in the media tends to focus very much on people with psychotic disorders like schizophrenia or some types of depression or bipolar disorder. And violence towards strangers. So random violence where someone will go out and kill someone on the streets. They've never met that person before. This is extremely rare. Now, the violence to family members in particular, and also to intimate partners, is a bit less rare. But it's important to see that also what we call the common mental disorders like depression can also be a risk factor for aggression. Again, a risk factor doesn't mean we know the causes, but we know that it's more likely to happen if someone has depression. Men who perpetrate intimate partner violence also have higher risks of depressive symptoms and of post-traumatic stress disorder. And some personality disorders also are more common among people who perpetrate intimate partner violence, particularly the more severe, moderate and severe end of the spectrum. The personality disorders would be particularly the emotionally unstable personality disorder, and dissocial, or it used to be called antisocial personality disorder, where the person has kind of less empathy and sometimes, often higher rates of criminal behavior. With emotionally unstable personality disorder, it's important to remember that in most cases, any violence or aggression that person has will be directed towards themselves rather than to others. But as we can see, it can also be associated with IPV. Finally, people with psychosis, they are at high risk of perpetrating violence against their families and carers. And it's a very difficult conversation to have, particularly, as I was saying, in the media, because there is a lot of stigma. We need to be very careful to explain that there is not always a causal relationship. Some people with psychosis are violent towards the family because of issues to do with, coercive control. Same things that happen in the intimate partner violence, or it may be to do with drug use. It may not necessarily be because of their psychosis, but in some cases, psychosis do play a role there. But as I said, the relationship between psychosis and violence is very complex. Sina Fazel, a researcher from Oxford University, is someone who has published a lot on this, and I cited here his 2009 paper, but there was a more recent one from 2019 that explored this more as well. I've put this slide here just to ground us on why this is important, So as we can see here, I believe most of you know this man, Sir Patrick Stewart, and he's a fantastic actor, very kind of talented man. And here he is, just last year saying, I'm 8 years old and I'm still in therapy to deal with seeing my mother being beaten by my father. So it's so vital for healthcare services to think about the impact of domestic abuse beyond the present, even though the present sometimes will be, urgent and crucial. But often we see families where they may say, and when I say they, it may be the survivor, they may say, oh, this happens at home. I am, say, shouted at or assaulted or coerced or controlled. My children are always upstairs in their bedroom. It only happens when they're asleep and they don't get exposed to it. As much as someone can try and protect their children, the children, we know from research now that 9 times out of 10 children do know that domestic abuse is happening in the home, even if they're not directly, even if they're not directly affected by it, as in they are not themselves assaulted or emotionally abused. They do know, and they will suffer the impacts, and the impacts can be very, very long lasting, as we can see here in Sir Patrick Stewart's case. So it's just to think about, or always think family, always think child, and think the impact there. Now, thinking about one of the main things that we need to think about is identification, because health services, they will have, we, because that's where I work, we will have a number of tools to support survivors and to help perpetrators change their behavior. But we cannot do this alone, and we need other agencies. Sometimes we need social services, sometimes we need police, sometimes we need, other agencies even. So just by identifying healthcare, someone who is either a survivor or perpetrator, healthcare services are doing, or will be doing, an amazing work. But we do know at that moment we're probably not doing as well as we could. So the service user who is, for example, experiencing domestic abuse, they may not necessarily come to you and say, well, this is happening, and voluntarily disclose. There may be signs for us to look out for, and they are vague things. So it doesn't mean they always indicate domestic abuse, but someone who's always attending late or frequenting leasing appointment or not engaging, why is that? Is someone preventing them from coming to see you? Or having lots of vague complaints, vague symptoms, implausible explanations. Those symptoms could be the result of assault that the person doesn't want to disclose, or just vague symptoms coming from psychological distress. Inconsistent explanations from injuries, like anything like I fell down the stairs and got a black eye. The person being fearful, passive in the presence of others that come to the consultation with them. We know self-harming behaviors are more common in people who experience domestic abuse. Covering the body to hide marks, which can be from injuries from assault, and not wanting to receive letters or be contacted at home. This is really important because we need to check if it is safe for people to receive post at home, and ask, is that okay? Do you share the home with somebody else? And just say, we ask this to everyone, but is there any chance someone might open your post? That is very, particularly if you are going to write anything in that letter that indicates that you suspect domestic abuse, because this could, if someone else opens it and reads it, it could put the victim at higher risk. So if the partner or family member frequently cancels appointments on behalf of the person, always comes with them, never leaves their side, seems to be, bullish, or even sometimes overprotective, which could be a form of control, or very possessive, very critical, judgmental, and talking on behalf of that person. So these are signs to watch out for, and that's when you then want to talk to that person, to your client, your patient, on their own, and say, the way I normally do is just say, it's just normal policy. I just need to see people on their own for at least part of the consultation. And obviously, I know this is for you who work in DVA services, it's very obvious, but never ask about abuse or indicate that you suspect abuse if someone else is in the room, even if that person is not the suspected abuser. This is a fantastic paper by someone called Professor Diana Rose, who she's now retired, but she was a professor of service user research at King's College London. And she wrote this paper with the section of women's mental health, which is my research group. It's now a 10-year-old paper about why people who experience DVA sometimes don't tell mental health services that that's happening. As you can see here in this diagram, there are many, many, many reasons. Some of them have to do with feelings that the person has. So, for example, being ashamed, being embarrassed, blaming themselves, or may have to do with their own expectations about their gender or what's right or not in their culture. But there are things that we can address. For example, sometimes fear of consequences. There are things that we can't fully reassure people. We can't say you have 100% guarantee of confidentiality. We always will give that disclaimer and say, if depending on the situation, if I think that you or someone else is at risk, I may need to share with other services, but I will talk to you about it. I'll talk you through it. Fear of social services involvement is very prevalent. Fear of disrupting family, for example. Will the perpetrator know that I'm disclosing this, and will they take away my children? And fear that disclosure will cause more violence, because it often does if it's not managed appropriately. Fear of affecting their immigration status if they're here on a spousal visa, for example. One thing I find particularly sad is the fear that disclosure will not be believed. And we do know that unfortunately that is true, particularly if the service user has certain diagnoses that carry, different types of stigma. So, for example, people who have personality disorders, and then sometimes if they react to the abuse by protecting themselves in a way that may be violent or retaliating even, and then mental health services see this as, oh, it's mutual abuse, therefore it's less risk. It's not true. It's actually higher risk. So the perpetrators themselves can be doing things to prevent the disclosure. And obviously the fact that DVA itself can be often hidden, so that can be a barrier. Now, just having a very, very quick look at the questions here, just to say, can you give examples of psychoactive drug use? So I will go into slightly more detail when we talk about the reports that I analyzed, but cocaine, heroin, the most common drug used by people who perpetrate domestic abuse or domestic homicides is alcohol. So it's a legal drug, but other drugs are present as well. Yeah. Can you provide access to site to access to? Yeah, we'll have the presentation available later. Now, I'm very excited about this slide, which looks very kind of normal and simple, but I'm excited about it because it's comes from a paper that is going to be published in the next few days or weeks. So when I said to you that there is very little research on perpetrators and mental health, that's true. So in my doctoral research, to start addressing this, I did a systematic review of papers exploring how perpetrators of DVA engage with health services. And this wasn't specifically mental health because there weren't enough papers, but any health services. So there was a small number of papers, but qualitative papers, and most of the people who were interviewed were men who perpetrated intimate partner violence. So I can't necessarily say that these factors would be present for example, female perpetrators of DVA or people who perpetrate family violence. So just to keep that in mind. So just starting with the bottom part, which is the barriers to disclosure. The thing that this review really showed to me, and I think the real take-home message is, people who perpetrate DVA will not come to a healthcare service and voluntarily disclose DVA unless they have a reason to do that in their minds, and unless they trust that we are going to do the right thing about that information. Now, what's the right thing? They don't define, but basically, people often don't trust healthcare services about how they will understand or address DVA, which, to be fair, we can't blame them, because at the moment, as a whole, healthcare services, we are still not getting 100% right. So perpetrators will also fear consequences of disclosure. Of course, people will fear being reported to the police or being arrested, but they also fear losing contact with the children, for example. They also fear that it will lead to separation. Many perpetrators actually who have been convicted and who have disclosed abusive behaviors, including serious ones, will then say, I'm not a perpetrator of DVA. Why is that? We don't fully know, but I think there is definitely, in some cases, a lack of recognition of what is DVA. So particularly if it's not physical, or if it's not something that happens very, very frequently. So if people will say, I pushed my partner once or twice and they fell to the floor and got a bit hurt, but they were fine, they may say that this wasn't DVA because it was a one-off. So this is something that we need to address. And negative emotions and attitudes. So perpetrators also sometimes feel shame and feel embarrassed and feel guilt, but also some will minimize and say, or normalize that happens in every relationship. Now, it's not all gloom and doom, because there are factors that will help people disclose to healthcare staff they are perpetrating DVA. For example, when they're reaching a crisis point, or their behavior has already caused them negative consequences. So if people have been arrested or had any contact with criminal justice system, people have been banned from certain spaces, if people have, their relationships broke down, or they weren't able to see their children, they are more likely to then tell healthcare services and say, look, this happened and this is why. Active listening always, people will not disclose by saying always, look, I've been violent to this person. They will often disclose by saying, oh, things at home can be a bit volatile sometimes. And it's really crucial that we listen to that and try to explore. The availability of support, ideally on site, always important to help people disclose, but we don't know what kind of support people want exactly. Okay, so now that I've set the scene in the last 20 minutes with the research data. Now we will talk about the case analysis and review. So as I said, this was authored by Bear Montique, and these reports focus on cases that happen in London. The mental health chapter, as you can see, is about 11 pages. That's the one I contributed to. And I wasn't part of the decisions about the sampling of the report. So Bear sent me the 10 reports that had been selected by her and her team. Normally with a qualitative analysis, what I would do, for example, it's like I'm doing with another study, is I will randomly sample a number of reports and then screen for the ones that meet the criteria, say, that had mental health service involvement. But in this case, they saw these reports as these reports have important lessons. So because they have standing together, they participate in DHR report writing and sharing. They have extensive experience, so they chose these reports for good reason. But the method of analysis was thematic analysis. So for those of you who are not as familiar with the research terminology, basically, quantitative research, most of what I cited until now was quantitative research, is when you see numbers and figures and percentages. The qualitative analysis, usually the numbers of cases that we analyze are much smaller because it goes into much more detail. And the qualitative analysis is very much about people's experiences or, what happens around the phenomenon, rather than being able to give answers as in, most perpetrators will do this, or most survivors will do that. Anytime you see me talking about numbers, it's just to situate you on the sample, but it doesn't mean if I say 2 out of 3 reports have that, or this or that happen, it doesn't mean it's a 20% chance of this happening. Okay, so let's just keep that in mind. The aim was to see, what kind of lessons were there in terms of the responses of healthcare services to victims and perpetrators with mental health problems. Okay. Now, so I just want to spend a couple of minutes on these 2 tables that I have here with the cases I analysed. First, to acknowledge the victims, and obviously it's not their names that we see that in the first column, it's pseudonyms like in most DHRs, but I thought that we needed to acknowledge them. And second, just to situate you on what the cases were, just kind of as a brief summary. We have the first one, RB, was a woman who was killed by her ex-partner. And she herself had depression in the past, but the perpetrator was a man with depression and who was suicidal. And there were no children involved, but the perpetrator told mental health services that he was suicidal because of the separation. And he did say to services that he had thoughts of killing his ex-partner. So we can go into more detail into these things later. And the second one was Mrs. A from Merton. So she also was a woman killed by, in this case, a long-term partner. Her partner had emotionally unstable personality disorder, and again told services that he had thoughts of killing her before the homicide. On the HR3, you've got Takia, who was a man who was killed by his son-in-law. His son-in-law had paranoid schizophrenia and had been abusive to this man's daughter, to his wife. The victim himself had problems with drug use. He was in treatment for opiate and cocaine dependence, though this wasn't seen to influence the outcome. In the HR4, Roger was a man with multiple sclerosis, which is a long-term neurological condition that tends to deteriorate over time and associated with some kinds of disability. In his case, he did have disabilities. His carer was his daughter, who was a transgender woman who had problems with agoraphobia, a type of anxiety disorder where you had severe anxiety about going out, and had problems with hoarding behavior as well. And DHR5, we had Barbara, who was a woman killed by her long-term partner, who then later killed himself. So Barbara had recurrent severe depression, and her partner had depression as well. And I think this is the only suicides that we had in the sample. DHR 6, we have Charlotte, who was a woman killed by her ex-partner who had depression, post-traumatic stress disorder. And he didn't mention to health services that there were domestic problems at home and there was a difficult separation. The couple did have children. DHR 7, we have Rose, who was also a woman killed by her partner. Rose's partner had a history of psychosis in the past, including a diagnosis of schizophrenia, but was no longer felt to need treatment. He had a dissocial personality disorder. He was had been dependent on heroin in the past, and he was drinking alcohol. DHR 8, Agapito, was a woman killed by her ex-partner, and her ex-partner mentioned to mental health services that he became depressed and suicidal because of their separation, and there was a child involved, and the child was present. The child, about 2 years old, was present at the time of the homicide. It was harmed, but survived. DHR 9, we've got Lottie, who was also a woman killed by her partner. Lottie had personality disorders herself and self-harmed and used drugs. Her partner had dissocial personality disorder, substance misuse, and had been to prison for assaults on her. And again, there were children involved. And in the last case, Sophia was a woman who had depression and anxiety and had told primary care that there was domestic hassle at home triggering her anxiety. The perpetrator, this was the only case selected, but the perpetrator did not have mental health problems. Sorry. Now, going into slightly more detail on the perpetrator mental health themes, the first thing I analysed was what were the diagnoses. So out of the 9 perpetrators, so just to kind of confirm, all the perpetrators in the sample were male, and all but one of the victims were female. This is not representative of the overall DHR sample, by the way. We normally see a number of female perpetrators around kind of 20%. But in this case, depression and anxiety disorders were present. And I say here 3 out of 10, but actually if we include agoraphobia, which is also an anxiety disorder, it was 4 out of 10. Or 4 out of the 9 perpetrators with mental health problems. So this kind of really shows to us that when we think about the mental health and violence, it's not really people with psychosis necessarily. Common mental disorders such as depression, where we wouldn't normally think can lead to violence, are also overrepresented, though, as mentioned before, we don't know if there's a causal relationship. There were 3 with personality disorders. There were 2 with psychosis. One of them had psychosis induced by drugs, that being kind of street drugs in the past. And then at the time of the homicide, it was actually a medical drug. They don't disclose the name in the report, but it was a drug to treat viral hepatitis, which is known to possibly cause psychosis. There was 1 perpetrator who didn't have psychiatric diagnosis, but got in contact with mental health services because of a suicide attempt. And 1 who had 2 diagnoses, dissocial personality and drug-induced psychosis. So we see that it's just across the spectrum of mental disorders, we will see perpetration. Now, suicidality was a really big theme. We see that 5 of the 9 perpetrators reported suicidality to health services before the homicide. Out of those, 3 actually did say they were suicidal, did present to services being suicidal in the month before the homicide. And 2 did so and did say they were suicidal, and actually said they had thoughts or plans to kill their partners about a year before the homicide. In those reports, in all of the reports where there was perpetrator suicidality, mental health services focused their assessment on the perpetrator's risk to themselves, not on thinking about if the trigger to suicidality is separation or relationship problems, could that person in that relationship could the partner or ex-partner be at risk? And we'll talk more about that. And as you can see, there are 2 of these DHRs where the actual panel made recommendations. So as you know, those of you who are familiar with DHRs, after providing a narrative and an analysis of the incident and of the service contact, they will then produce their recommendations if needed. And in those 2, there were specific recommendations for NHS to assess risk of harm to families and partners in all patients who present with suicidality. I work in liaison psychiatry, and most patients I see in A&E present there because of suicidality. And I think the assessment of risk of harm we tend to do, that we are trained to do, is often focused on a general risk, as in, do you have any thoughts of harm to others? Where most often the answer will be no. Even though in some cases, as you can see here, 2 perpetrators did say before they had thoughts of plans to kill their partner. But I don't think we are at a stage generally in NHS where we are trained to assess risk specifically to families, because it's a different process, the assessment. Now, let me just see. Yeah, I've got this slide. What about the victim mental health and victim vulnerability? So we've got here one DHR where the perpetrator was the man with multiple sclerosis, and he was all reports are incredibly sad and shocking. This one was particularly so because you could see so many signs that the victim was being neglected in his care by his daughter, who did have mental health problems, and she wasn't offered a carer's assessment or carer support. And she was slowly, you know, kind of not taking him to appointments. And I think if there isn't anyone here, I saw a colleague in the attendance list who works with me in the diabetes service, but if there's anyone else here also who works in general healthcare, not mental health, you know, just keep in mind about, you know, your patients, those who are vulnerable or have disabilities, if they are not turning up for appointments. Is someone not taking them? Is that for a reason? And is there something else that you need to do or to talk other people to talk to? In one DHR, the victim was a middle-aged man with addictions and unstable housing and uncertain immigration status. His addictions didn't seem to have influenced the outcome. What happened was his son-in-law stopped taking his medication for psychosis, clearly got very unwell. There was no contingency plan from his mental health team. And this man was then living, the victim, you know, is living with him. Perhaps if he had stable housing and, you know, like his stable immigration status, he might not have lived with his son-in-law, and he might not have been exposed to, you know, be at risk of homicide as he was. In one DHR, the victim and the perpetrator had mental health problems and drug use. The victim was a vulnerable woman, self-harmed, and agencies, particularly mental health, seem to place a lot of responsibility on her to protect herself from a relationship. And when she didn't do that, they took it as disengagement and lack of interest, rather than understanding the dynamics of coercive control and why a survivor of abuse will sometimes not be able to stop the abuse. In these 2 DHRs, 5 and 10, the victims had depression and anxiety, and they were never asked about DVA. And I appreciate that, you know, let's say if someone is working in primary care, the numbers of people coming to see you with depression and anxiety are incredibly high. But these 2 DHRs show that it really is worth asking a bit more about how things are at home. Was there anything that may have precipitated your depression or anxiety or making things worse? One of the victims did say, oh, there's a lot of domestic hassle at home that's making me anxious. And this statement apparently wasn't probed a bit more. So she was never asked specifically about DVA. Which also means that if she hadn't been killed, you could not expect her to get better just from treatment of depression if there's something happening to her, you know, influencing that. Now, substance use was present in 3 of the reports. One of them, as I said, was the perpetrator. It was the victim, where it didn't really affect the outcome. But in the DHR 9, the victim and the perpetrator used drugs and were known to mental health services, they were referred to addiction services, but they never engaged. So the engagement is a tricky word, because it's when we as clinicians are making a judgment call as to whether someone is taking what we're offering, without thinking what we're offering, is it what they need? Are we offering it the way they need it? And with addiction services, the engagement is usually voluntary, and the person will needs to turn up for appointments. And these two people, they did not. So their addictions were essentially unaddressed. It's also a problem of the splitting between mental health and addiction services, because the mental health services are not as well trained to deal with addictions. And then if the person doesn't engage with another team, there's nothing else they can do. Now, one perpetrator used to drink alcohol, and I believe he was dependent on alcohol, had dissocial personality disorder. So the combination of alcohol, drug use, and personality disorder is associated with his risk of violence, as we saw earlier. He had an episode of drug-induced psychosis that required admission under the Mental Health Act many years before the incident. So what happened was that he developed a hepatitis. His partner was his carer, and he was prescribed medication for viral hepatitis, which was a medication that had possibility of inducing psychosis. And the team looking after him, the hepatology team, were actually very careful about assessing him, but they didn't ask for specific information about his mental health and risk history. And the problem is the GP actually did not have the information, because he had moved from a different area and they hadn't received the full records. So one might think that if the hepatology team had known this man had been sectioned before because of drug-induced psychosis, they may have been either more hesitant or more careful in terms of prescribing that drug. They did offer him psychiatric follow-up, but things happened very quickly. And the last one we've talked about. Interagency working. I'm sure those of you who have been to these webinars before, it comes as no surprise to you that interagency working was a problem. I'd say a big problem there was that agencies often focused on only what's within the very, very, very specific scope of practice. For example, someone comes in saying, mental health services, I'm depressed, I'm suicidal. And then the service will assess them for depression, for suicidality, for risk to themselves, and stop there. Services won't think what's around this, and we all know that services are underfunded, are busy, and this is all true. But knowing what we knew, going back to those first few slides and knowing the very, very strong association between mental health problems and DVA, we cannot not ask, we cannot not think about the impact on the family and the impact of the family on that person as well. So one big message was services need to think about that person's life as a whole, and who else might be affected by those behaviors. There was a lack of effective partnership between agencies. Sometimes agencies did not share information at all. So in some cases, there were children, and there was usually a man coming to mental health services saying, I'm suicidal and depressed because my partner is leaving me, I can't see my children. And in one case, the perpetrator said, I want to take my child without my ex-partner's knowledge and take her to live in another part of the country with me, which is child abduction, which is a crime. And mental health services did not think of that as a safeguarding issue, did not share that information with social services at that point. So this is a case where the partnership doesn't even happen. And there are cases when the partnerships do happen, but the information sharing isn't as good. And there isn't like a multi-agency meeting, for example, which means that actually each service is left with a very incomplete view of the person they're treating. So it may be that if I'm a mental health clinician, I'm treating the perpetrator, I will only know what that person's telling me if I'm not getting collateral history from the family, if I'm not getting information from other services. And knowing now how many barriers there are for perpetrators and survivors to disclose, we can't always just rely on people's account. We need to go and find out more information. Like I said, in 2 DHRs, there were significant child protection concerns, including one that I mentioned now with the risk of child abduction. but the joint working wasn't happening. And in 2 DHRs, the information sharing just had kind of very significant gaps in that risk information or historical information was not shared. Still in interagency working, we talked about the medication case, and the DHR4, the one with men who had multiple sclerosis, there were indicators of neglect, financial abuse. There was a safeguarding alert raised, but the GP was not informed of it, and there was no multi-agency strategy meeting. So the agencies couldn't really, partner to protect that person and find out what was going on. Carers was a big one. We know, just going back a tiny bit to the research data, the carer role is associated with something called caregiver burden, which is, psychological distress, basically. The risk is particularly high when the carer lives with the person they're providing care, which is very common from a carer coming from the same family. And if the carer themselves have mental health problems. If there is a conflict between the relationship and carer strain, a history of physical mental health problems in the carer, or the carer and the person receiving care live together, these are risk factors of abuse by carers. So we know there can be abuse by the carer, and there can be abuse from the person who's cared for, right? So we see here a couple of cases where, in two DHRs, the perpetrators were carers for the victims, and they were clearly not coping with their role. When I say clearly, just to open here a parenthesis to say, everything is clear once it happened, right? So it's very easy for me to read a report where a lot of information was collated and say, obviously it was there, but we do know that, often we have a very high number of caseloads, and everyone's really busy. But even without those factors, it's very hard sometimes to spot some things. But in one of these cases, in particular of the man with multiple sclerosis, the signs were there, but they weren't picked. They were picked up, but they weren't acted on effectively. So in the DHR5, the carer strain was one of the reasons why. So basically, this one was a man who was a carer for his wife who had recurrent depression and was no longer able to work. And this woman was then discharged by mental health services because they said, we've offered you everything we could, but that's kind of it. You're going to remain on medication and your GP will manage. And then this man, who had a history of depression himself, was diagnosed with cancer. I believe it was prostate cancer. And his cancer was not terminal. There was treatment and the prognosis was good, but he got into, you could call it a spiral of depression and anxiety, where he catastrophized and thought that he was going to die and his wife would be left without any care. He accessed mental health services. He was referred to a CMHT, a community mental health team, had an assessment, and they said, look, we know you're depressed, but you don't quite meet our threshold for treatment, so we're going to stay with your GP. And the GP was very good and was trying to kind of, I think, start him on treatment. But no one stopped to think about, what does that mean for you as a carer for your wife? And then he ended up later killing his wife and killing himself. So both of those cases with carers, there was suicidality. One actually killed himself and the other tried to, but didn't. And in one DHR, which was for the man who was in the liver medication, the victim was the carer. Now, what were the responses to the disclosure of the VA? And I'm just going to try to speed up because I promised to keep it within an hour. But I know I have a few more slides about how we can respond better. But really, here we can see, in some cases, services expecting victims of survivors of DVA to be really proactive about protecting and managing the risk to themselves, which is a very hard task for them to do, particularly if there is coercive control. The reasons why someone might not disclose or might minimize the impact of DVA were not really understood by mental health professionals. So if a survivor says, oh, this happened, but it's not as bad, then professionals are often taking this as, okay, so that's low risk, when in fact it could be higher risk because the survivors are minimizing. Like you said, in some cases, there were tentative disclosures, there were hints that were not explored. So that's a problem with the service response. With perpetrators in particular, whenever they disclosed DVA to services in this sample, it was always as a hint, as kind of a very vague thing. So they would say, the reason I'm feeling depressed is because I'm separating. And services will often not think of the victim, of the survivor, and think, well, they've separated, so there's no risk. And those of you who work in DVA services will know that actually this is the period of higher risk. The 6 months post-separation is the high risk period for homicides, for domestic homicides. And I think mental health services, that message hasn't gone out yet fully and been incorporated by services. So people, accessing their partner's emails or planning to abduct their child, they're not being recognized as DVA just because that person didn't say, I hit someone, I hit my partner. Or oblique references, as in, there's domestic hassle, or things are a bit volatile, or sometimes disclosing injuries and attributing them to domestic incidents, but then this is not explored. With risk assessment, the big issue there was that mental health services were not involving partners. They're not getting collateral history. So when we work in mental health services, we know that collateral history is such a vital part of our assessment that we normally have to do it as routine, usually only if we really have a good reason not to, that we will stop and not seek collateral history. But in these cases, there was a need for collateral history. And the perpetrators were saying, 2 of them said, I do have thoughts of killing my partner. And in these cases, the partner was not contacted to think about, how is this person doing? That risk wasn't managed beyond saying, oh, it was just a thought, there are no plans. So nothing was done with that information, basically. Or people saying the reason why I'm being unwell is because of problems with my partner, or partner being a carer, or the perpetrator being a carer. None of those cases the partner was contacted for collateral history. Of course, there are issues with confidentiality and information sharing with families, but there are ways this can be done safely. In some cases, the risk assessment process was flawed because either not sufficient information was sought, or a perpetrator wasn't entirely fluent in English, but was not seen with an interpreter. The DHR 7, we've talked about that already. Follow-up was a problem in terms of one perpetrator with psychosis who stopped taking his medication. There was no contingency planning. One perpetrator, the one where both victim and perpetrator had mental health problems, he was released from prison for DVA related offense. There was no provision for housing for him. There was no provision for his mental health follow-up. And then he moved back in with the survivor, with the victim. And then the homicide happened. And the DHR 5 was the one we talked about, was the homicide suicide, but the perpetrator felt that he couldn't be a carer anymore and catastrophized about his diagnosis, but no one explored with him what that meant for him as a carer. Did he need more support? Did he need maybe a care package for his wife, or social services to step in, or counseling sessions or whatnot? This didn't happen. So as a summary, those were the themes that we picked up, that I picked up in this analysis. And so essentially that mental health symptoms and mental health diagnoses are across the board. Common mental disorders and psychosis and personality disorders all prevalent there. There's a lot of vulnerability, particularly in the victims, some substance use, and as I said, particularly alcohol. Interagency working was problematic, and carrying responsibilities not fully kind of understood. The response to DVA by agencies also had some flaws as the risk assessment. And here we can compare. So many of you know that the Standing Together published an analysis of DHRs in 2016, but those were all England and Wales DHR, was a sample taken from all those countries, whereas 2019 was just London. Some of these overlap, So depression and suicide in perpetrators was definitely a theme there as well. Substance use, carers, problems with interagency working and transitions of care, problems with treatment and medication. But in this report, we also picked up things like the vulnerability, particularly among the victims, the risk assessment process. So the take-home messages from this are basically that when we work in healthcare, we really need to think about the risk of DVA, both perpetration and experiencing or kind of victimization, which we don't like to put it this way, but being on the receiving end of DVA, because people are at much higher risks, 4 times higher in terms of lifetime use. In more than half of the cases we analyzed, and like I said, this doesn't mean it translates to the general population, that will be half the cases, but here, more than half, people made disclosures to healthcare teams about their relationship problems and DVA, but these are often in very indirect ways, so we can't expect survivors, and particularly perpetrators, to come to us and say, I'm assaulting someone, I'm abusing someone. They will say in different ways, and we need to really explore these things. Disclosures were not, even the disclosures were not seen as indicative of DVA or followed up by collateral history. Agencies did have policies for assessment and management of DVA, but I think the policies were perhaps not entirely clear. There is a need for more clarity there about how do you recognize these indirect signs of DVA? How do you inquire safely? How do you respond to the inquiry? And what's your network for dealing with this problem? Clearly, it's something that healthcare services can do a lot better on, but it's not a problem that can be addressed by one agency or one team. Collaboration, is something that obviously standing together works, particularly with that. This is something that is vital. Information sharing, joint planning, all of this is crucial to deal with this problem effectively. Before we go to Q&A, I just wanted to take a couple of minutes to go through some of the suggestions that come from the Lara VP resource. So I will just look for the link and just pop the link on this chat in a few minutes. But basically, we need to have information about DVA in the team base. I see this in a lot of teams, definitely teams like perinatal psychiatry, but we need to have it in every mental health team, ideally in every healthcare team. When asking, always ask in private with the person on their own. A child will have to literally be a baby who is not able to speak. Any child who can speak is not safe for them to be there, because they can repeat things at home and put the victim in higher risk. Even if it's the victim's mom and she says, oh no, it's absolutely fine, my mom can be here, just try and say, I would really prefer that you be on your own. It's just our policy. Choosing an appropriate interpreter, never using a family member or friend as an interpreter to ask about DVA, because you can be putting that person at higher risk. Being clear about limits of confidentiality. Fears about confidentiality are a barrier to disclosure, but we need to be honest with people and say, if you say something that is really worrying about risk that someone might be hurt, I will have to talk to other teams. And then you can talk them through the process so they can understand how you would do that. And these are kind of ways to ask about DVA to help healthcare services. It's usually for people who you think, who are assessing for experience in DVA. Do ask men about this as well, not just women, because men with mental health problems are also at risk. So there are some ways of kind of just saying, it happens a lot. 1 in 4 women, 1 in 7 men. Has it ever happened to you? Has anyone hurt or frightened you? So the way I ask is just first by saying, I ask this to everyone, and then saying the reason is just important because we know that these things affect people's mental health. And then we'll go through kind of emotional abuse. Do you have a lot of arguments? What happens when you argue? Those open questions, what happens when you argue? They can open up a lot of information for you. How are things at home? How are things with your partner? Have you ever been afraid? And then you kind of start narrowing down to physical symptoms. It is useful to name certain behaviors rather than saying, have you ever had physical abuse? So has anyone kind of pushed you or, hit you or something like that? If someone discloses, it's important to know what was the worst that has happened, because people sometimes will disclose just the very tip of the iceberg and they won't say the real worst thing that has happened. So we need to ask, and the effect it had on them. So it could be someone disclosing initially just some arguments, and you ask the worst. Well, there was one day when they pushed me down the stairs and how it affected me. Or actually I had a broken rib or not, or a mental health. I felt suicidal. If you ever need to attend a hospital, police being called, injunction. I guess in healthcare, you know what I'm talking about, but we can be surprised by how much information comes out once we start asking, we set the scene properly and ask more specifically, how frequent it is as well, and not always if there are children around in any way. Asking about DVA perpetration is a little bit more difficult. We have less guidance on how to do that. One of the things to ask is who supports you at home. So it may be that, so that will tell you who are the people who are at higher risk of receiving any abuse. And then how are things with family? What happens when you argue? Has that ever led to, you lashing out, for example? Have people said they are frightened by you? And I always kind of start by saying, this happens to a lot of people. That's why I'm asking. It's nothing to do with you specifically. I just ask this to everyone. Or if there was a reason why you asked, then, by all means, we can say that. If you ever felt your behavior got out of hand, what was the worst? What was the effect on those around you? So people may say that they don't do very much, but, oh no, but I do notice that my father or my mother or my partner, they just kind of start crying when this happened. So this is a kind of cue to saying the effect is very serious. Risk indicators. Obviously, if someone has a history of DVA, they will be at risk of further DVA. Using weapons, which can be any object at all. Oh, they threw something at me. This is actually use a weapon. It doesn't need to be a knife. It doesn't need to be, a firearm. Threats to kill that person. Unfortunately, I have read a fair number of DHRs where someone did say they wanted to kill their partner, and this was not taken seriously. Threats of suicide. Threats of suicide can actually be a form of coercive control. To say, if you leave me or if you do this or that, I will kill myself. Traditional concept of masculinity, obviously diagnosing mental health problems, as we know, in alcohol, substance use. And then, as you say here, it may be helpful to talk to partners, family members, or carers in private. Okay, and you can say, I can explain to your service user, I normally talk to families on their own because it's just our way of working to support them. If they're very reluctant to do that and you're very concerned, talk to your trust safeguarding lead, because there will be ways when you can do that safely and preserving patient confidentiality as much as possible. Recent separation, pregnancy, all of those things, very important signs of risk as well. Recent separation makes a lot of clinicians just breathe a sigh of relief and say, okay, so there's less risk then. No, there's high risk. Information sharing, I guess, most of you here will know a lot about that. Consider talking to the police if you believe it. And there may be cases when you will have to disclose, even though the person hasn't given you, even though the perpetrator or the victim hasn't consented to the disclosure. There may be cases when you need to do it anyway, but again, involve your safeguarding lead. Social care, particularly for vulnerable children, MARAC, multi-agency risk assessment conference, and MAPA in certain cases, and the multi-agency safeguarding hub for children. Right, so these are my references, which you have in this, and my Twitter handle if you want to connect and talk to me more about this. And I guess we're going to go to questions now. Hannah, do you want to chair, and have you picked questions?
Yeah, absolutely. First of all, thank you so much, Dr. Calcia. That was such an insightful presentation. I don't know if you've been able to see anything on the side, but people have been thanking you for all the insight throughout this. We have a few questions in the QA. If anyone else does have questions, if you can please pop it in the QA, just because we have some great comments going on, but it's a little bit harder to find the questions through all the comments, so if you can pop them
Okay.
in there. But I will, I'll go through the ones that we have now, if that's all right. A few of them you might have slightly covered, but I'll just ask just to make sure that everyone's clear, if that's all right. So the first question is, somebody asked if there's any helpful tools to assess family risk when someone is suicidal specifically.
Good question. I don't know about specific tools. So we have tools for risk assessment for risk of suicide and risk assessment for others. One very specific that assesses risk of domestic abuse for suicidal people I'm not aware of, but there is the DASH risk assessment that we do not routinely use in mental health services. But I think if someone is disclosing suicidality, you know that they have partners or family around them who may be at risk. And particularly if you see one of those signs, like, you know, recent separation, pregnancy, victim survivor pregnancy, history of DVA, then I think there needs to be an assessment of risk to others that, even without a structured risk assessment form, is more about gaining collateral history and talking to other agencies and talk to your local safeguarding leads as well. But in terms of a structured one, will be the DASH.
Great, thank you so much. And this next one is a short one, but I think it's probably quite loaded for it as a question. So please go into as much or as little, as much as you can. But they've asked if you know why that interagency information sharing and contact that you mentioned didn't happen.
Very good question. I think sometimes with some of the DHR reports, it's difficult to know the why of things. You know, sometimes what happens, and you know, if you're lucky, you know how. But why is tricky, because the DHR panels don't always interview the practitioners themselves. They basically get a report from that agency and take it from there. But for example, in the cases where there were child protection concerns, the case of the man who wanted to abduct his child, it was basically not seen as a child safeguarding problem. It was not recognized as such, so people didn't feel the need to then make referrals or things like that. So that's one of the reasons, just lack of recognition of what's DVA and what information you need to share.
Thank you so much. The next one I'll read out is, first of all, thank you for a great presentation. My question is whether there's any information or data available from either your work or associated with the LARA VP to support and guide mental health and other professionals to ask evidence-based, specific and detailed questions to DA perpetrators who have made threats to kill a partner or a family member, such as an assessment checklist. An assessment checklist of this type would be very useful to establish how likely such threats are to lead to a severe life-threatening violence or murder.
Mm-hmm. Great question, Mark. So threats of kill a partner or family member absolutely always must be taken seriously, and threats to kill are a crime. I've had enormous difficulty when I had a patient of mine who threatened to kill an ex-partner. When I was communicating with the police, I had enormous difficulty getting the police to understand the problem, because they said, oh, but this man has mental health problems, so maybe that's why, when in fact it increases the risk. So the LARA VP resource, I'll send the link to Hannah, but that has a lot of helpful questions to assess the risk. But I would say in the case of threats to kill, so the DASH risk assessment, that itself will already make the DASH score go high. And then you basically need to talk to the local safeguarding lead in your trust or in your organization and talk to them about how you're going to disclose to the police, because there are some cases where they know about potentially to think how to have patient confidentiality, but the risk to someone else's life will trump that. And then you probably need to involve the police. So I'll start with the DASH risk assessment and then trust safeguarding leads and having a really kind of serious conversation about how to get the police involved.
Thank you so much. The next question is, I'll read out. We recommend to add in the PHQ-9 forms when we ask about, do you have thoughts about harming yourself, to add, do you have thoughts about harming another person? And I suppose the question is, what are your thoughts on that?
Yeah. So that's true, Senate. There is a DHR report. I don't think it was in the sample, but it's in another sample that I'm analyzing, where the panel recommends that primary care start assessing risk to others in people who are at risk to themselves, people who are suicidal, basically. And I don't know, the problem with some of the DHR recommendations is that what happens afterwards, you know, kind of how are they implemented and how are they tracked? But assessing risk to others is very difficult. And when we ask that question about, do you have thoughts to harm someone else? I have to say, in the vast majority of patients I've assessed in my career, the answer will be no. And if they say yes, the answer will be yes, but I won't do it. So when there are other ways that we can assess risk to that person, even if the perpetrator isn't disclosing the thoughts to harm them, person. So those who indicate risk. So although I think it would be helpful to add that as a question, the problem is don't pick up everyone. And it may pick up some false positives and leave GPs, you know, without knowing what to do. So perhaps it's about kind of implementing that with training.
As we all know how important training is and making sure that tools are useful. Someone in the comment just before I move on to the last question on there is stated, with regards to the use of dash, that specifically for use of victims, is there a similar type form if it is the perpetrator that you're seeing and they disclose that they're thinking of killing their partner? Someone has also put in the chat regarding respect, which has some toolkits about perpetrators, but do you have any other thoughts or to add on that? Dr. Calcia, I'm not sure if you're cutting out for anyone else, but I think you're slightly cutting out for me. I'm just gonna stop my video to see. Oh, I don't know if she's just dropped off. I'm so sorry, everyone. It looks like she has dropped off the call. There must be some internet issues, as I'm sure we're all very accustomed to dealing with right now. Just in case she isn't going to come back on, I'll kind of do a little wrap up, but if she does pop back up, then we can get to the rest of the questions. But what we will do is, if you have any questions, oh, how you're back. Are you on mute? Oh, Dr. Calcia, you're on mute.
Sorry, my internet got a bit wobbly. I was just emailing you to say I'm trying to come back. So the question was about assessment tools for perpetrators for risk. To my knowledge, I don't believe there are any at the moment. There are specific risk assessment tools for violence. And there's one called HCR20 that's used in forensic services. But those tools, they haven't been specifically tested for DVA perpetration. So it's something that at the moment is a bit of a gap. So the risk assessment is more kind of a informed professional assessment / decision tool rather than a structured one. No, yeah, so Michelle said that there are screening tools to identify perpetrators. Would that be okay if I ask Michelle to say, you know, which ones do you know of, Michelle? Respect toolkit. Is that for people with mental health problems as well?
I think respect, because I'm aware of the respect toolkit, and it's more general, but it is really useful, especially when you're unsure who the primary perpetrator and primary victim is. It's designed to try to help you identify perpetrators in essence, but I don't think it's specific to mental health unless there's an aspect of it that I'm not aware of, and someone please can correct me if I'm wrong. Yeah, so I think, you know, it's something that you know, probably we need to think about developing a specific one for people with mental health problems, because like we said today, there are different types of mental health problems. We can't say all of them have a direct relationship with perpetration, but yeah, they definitely change the way the risk is assessment. But thank you so much, Michelle and others. As Shana Begum said about Sarah V3, yeah, that's really good. Be safer. I'll definitely look those up. Yeah, thanks. And just to say, definitely standing together in the MARICs that we run, we definitely recommend that respect toolkit to frontline workers in trying to assess primary perpetration or assessments of that type. So if you're not aware of it, I do recommend checking it out. And I don't think it's exactly to work with perpetrators, but I know there's some MATAC processes that are in place. And kind of Drive has done some good stuff around perpetrators. So if people are interested in that, I can try to see if I can finagle anyone to come and do a session kind of looking at perpetrators more widely. So perhaps in the future. So the next question on it, and I'm not exactly sure. So Paul Smith, if you do want to clarify, or maybe Dr. Calcia, you know what it's in reference to, is why aren't housing providers considered partners?
So Paul, they are. It's just that in the reports that I was given to analyze, housing providers weren't kind of involved with any of the mental health process, or they weren't mentioned at all. There was only one perpetrator, no, actually two perpetrators, one perpetrator and one victim had housing problems. And in one case, the perpetrator was then released from prison without housing. And that was a big problem, but it wasn't a problem with the housing provider themselves. It was a problem with the processes within prison before the release. But definitely they are very relevant partners here.
Thank you. And there's another question. Is there a relation with spectrum disorder with perpetrators?
Yeah, if I think you mean, do you mean autism spectrum disorder? So I'll carry on as if you mean autism spectrum, but if not, correct me and we'll change. But it's complicated because people with autism spectrum disorders, they can be, because it's a spectrum, people can present very, very, very differently. So there are people out there with autism spectrum disorder who are, you know, fully kind of working and having families, and whereas others are in a full-time care home setting. So there have been some DHRs, a few, I have to say, where the perpetrator had autism spectrum disorders, and it was felt that the violence did have some relationship with the autism spectrum disorder, particularly because, you know, sometimes people with autism spectrum disorder will not understand the consequences of their violence, so they will basically assault someone thinking it will be something very minor in reaction to their frustration or misunderstanding, and they won't understand that that assault can actually kill someone. But it's a relatively small research base. It's more research around forensic psychiatry in terms of violence in general, and you see a lot of it is called challenging behavior when people with autism or learning disabilities have behaviors that can actually be violent. But in terms of DVA, there is fairly little.
Thank you so much. And another question is, how do you view this with consideration to population health management?
So it's a great question, because in a way, if you think of how prevalent DVA is, and say in the statistics in the UK, kind of in the past year, you know, it's between kind of 10 and 20% people experience DVA in the past year only. We can't help but think about what's the impact of this in the general population, and how people, you know, like even things like impact on days off work, impact on use of healthcare services, people sometimes needing more care, and the spend on the cost to the NHS is in the billions per year, just directly related to DVA, for example, for injuries or for mental health care. And when we think of the perpetrators, so when we think of the survivors, it's more about, we have to think about the preventative space, you know, and thinking about when we see people who are at risk, how are we supporting them? And when we see people already giving us warning signs something's happening, how do we stop that? How do we help them stop this becoming something worse? How do we empower them to manage that? Whereas when we talk about perpetrators, it's not so much about the consequences of perpetrators to their own health, but to other people's health. And just thinking in healthcare, when I see this group of people, which are mostly people, usually men, with mental health problems of any kind, plus or minus substance use, plus or minus a personality disorder, who have given indicators of history of violence, which is not always present, by the way. In a lot of the DHRs we analyze, we will see that that perpetrator has never been violent before, but there are some signs there of, slight control in relationships and things like that. So yeah, no, long-winded answer to say, in population, if you split survivors and perpetrators, we need different strategies, and then we'll focus on prevention and kind of secondary management. But the spend is massive. 3 women end their lives every week due to domestic abuse, says Sanya. That's absolutely true. In the DHRs we analyzed, there are some CSPs who do DHRs, isn't it, Hannah, who do commission DHRs for those cases. None of them were in my analysis, but it's crucial, it's vital, because mental health services, we often struggle so much to help people who are suicidal. No amount of medication, no amount of psychiatric admission or psychological therapy, if it's not done, in a DVA informed way, will then help that person stop being suicidal, because there's something happening in their lives that is making their lives miserable.
Absolutely. And actually, if people are interested about that topic a bit more, our next session is focused on I can't remember the title of it now, but it's in essence non-homicide domestic related deaths. So under that umbrella, where we'll have Sarah Dangar, who is at AFTA, but is also doing a Winston Churchill at the moment on just that subject, who's going to speak about her research. So under that umbrella is suicides, but also things like health complications that have been a result of domestic abuse, or when survivors use substance use in order to cope, or are enforced to be dependent and then die as a result. So if you are interested on that topic, please do come along for that. We have a few, another comment over here around, I think it's more of a comment than a question, but just to say, to support healthcare providers, housing providers hold a lot of information and have DV specialists so they can contact them for help and support if either party lives within social housing.
That's really helpful. That's, because not all mental health services are able to do home visits. And sometimes there's so much that we don't know about people's lives. So much we find out just by, either going to their homes or talking to someone who's managing the situation there. So that's really helpful.
And I think with that, we've covered all the questions, which is great timing, actually, because we're just coming up to our last couple minutes. So I just want to say again, you can see all the comments probably coming through. It's been such an insightful and useful conversation to have with you. Thank you so much for taking the time of your lunch to come and do this and share all of your insight and research. We'll be sending out the video from today, slides, and if there's any other links, Dr. Calcia, that you want me to send around when I send that email, I'm more than happy to kind of include anything else that you want included that we spoke about today. So just let me know.
No, I just wanted to thank people for coming, for asking questions, and I know it's a difficult topic, and those of us who either work in the sector or study it, it can take a toll on us as well. So if this presentation today triggered any kind of difficult feelings on you, then by all means, look after yourself, take your time. And I want to especially thank the people who commented and helped answer the question about the perpetrator risk assessment. That's why I love doing a presentation like this, because then I end up learning more than I share. So thank you, that was really useful. And thank you, Hannah, for organizing this.
Of course, and I have to thank my team as well that are behind supporting Helen and Helena. That make sure everything gets going. But yeah, thank you so much. Please, if people can take a moment to fill out the survey, it's just great to have feedback for both of us. So if you can just take a moment to fill that in. I've already mentioned the next session, and I think I've covered all the other housekeeping bits, hopefully. If not, I'll pop it in the email for the follow-up attendees. So just thank you so much, everyone, for coming.
Thank you. Bye.
Bye.